So welcome to everybody who's registered with this seminar with Dr. Monica Embers, hosted by Lyme Disease UK. We're really honoured to have Dr. Embers with us today. And thank you so much for giving your time to us this evening. Just a bit of housekeeping first. This seminar is being recorded, so you don't need to sit and try and take any notes, because everybody who's registered will get a copy of the recording after the event, and it'll probably be tomorrow or the next day before you receive it. Please keep your microphones and videos off throughout the seminar, because it's really distracting to the speaker if you keep switching them on or you put your microphone off. So if you could keep to that. And there is a moderator in the background who, if one goes on accidentally, she will switch them off. Time permitting, we'll be taking some questions from the chat box at the end after Dr. Embers' presentation. So you can put your questions in the chat box and we'll try and take as many as we can. So a little introduction to Professor Embers, Associate Professor Embers. Dr. Embers. Dr. Embers is currently an Associate Professor in the Division of Immunology and the Director of Vector-Borne Disease Research at the Tulane National Primate Research Center. Her research program regarding Lyme disease and its infectious cause, Borrelia burgdorferi, specialized in animal models. The research is centered around three major efforts. One, identifying treatments that can eradicate Borrelia burgdorferi, I can't speak to this evening, but burgdorferi infection. Treatments that can, to detection of persistent Lyme disease spirochetes in human tissues, in brackets, autopsy and surgical discard. And three, immunodiagnosis for Borrelia burgdorferi, I can't say that this evening, infection and cure. By transmitting Lyme disease to mice and non-human primates by tick and studying the natural course of infection, her group aims to obtain a better understanding of the clinical quandaries of human Lyme disease, including effective diagnosis and treatment. Due to the many similarities between Bartonella, osis and Lyme disease, her team has begun to develop research models for Bartonella infection and assess vector transmission of this pathogen as well. So it'd be absolutely wonderful. Over to you if you would like to share your screen, and we'll all watch your presentation avidly.
Thank you so much, Julia. Thank you to Lyme Disease UK for the invitation. Can you see my screen?
I can see it, yeah. I'll turn my video and microphone off, but if you want me to come back, just shout and I'll come back.
Okay, wonderful. Thank you. So I guess I don't need to introduce myself again. Today I'm going to talk about some of the work that we've been doing with persistent Borrelia burgdorferi infection. And we have not only looked for the presence of persistence after antibiotic treatment, but we're also working towards better treatment options. So I'm calling this supportive evidence and potential solutions. So not long ago, this report was released, and it has to do with post-treatment Lyme disease. And so this is an estimation of the number of people in the United States who probably are afflicted with post-treatment Lyme disease. And they say that although most patients are successfully treated by timely antibiotic therapy, it's broadly accepted that a sizable number of patients experience treatment failure and continue to suffer long-term debilitating symptoms. And we know that it's somewhere between 20 and 30% of people who go on to develop post-treatment Lyme disease. And based on their estimate for accumulative evidence of patients who are diagnosed with Lyme disease, and assuming that 20% of patients go on to develop post-treatment Lyme disease, the estimate is that in 2020, there were at least 2 million cases of people who are suffering from post-treatment Lyme disease. And so what is post-treatment Lyme disease? It's different. It's actually distinct from fibromyalgia, depression, chronic fatigue, in that patients with chronic Lyme disease have fatigue, musculoskeletal pain, and neurocognitive difficulties. Those are the three primary symptoms associated with post-treatment Lyme disease. And John Alcott, Dr. Alcott at Johns Hopkins University has gone to great lengths to define and characterize post-treatment Lyme disease. And so what are the potential causes? Well, we know that one potential cause is that we're not curing the infection. So that is the continuation of active spirochetal infection. There's another potential cause that a lot of rheumatologists favor, which is that there's the induction of inflammatory responses by lingering dead spirochetes or spirochetal antigen, and that there are irreversible sequelae from a previous active infection, i.e. that it's autoimmune. So when we think about how to treat this bacterial infection, we need to consider some things. And first of all, the primary drug used to treat Lyme disease is doxycycline. And this antibiotic is microbiostatic, which means that it does not directly kill the bacteria. And its efficacy relies on the ability of the immune system to clear the infection of static bacteria, so bacteria that are not growing. And we know from multiple studies that Borrelia burgdorferi evades the immune response in many ways, and in some cases it even can suppress the immune response. So persistence is the norm in immunocompetent hosts. So you can't rely on a treatment that needs an immune response to clear the infection. We also know that dormant bacteria are more tolerant of antibiotics that are microbiostatic. And we know that Borrelia burgdorferi survives many months inside ticks without nutrient replenishment or replication. So dormancy is part of its life, part of its cycle. And there was a study many years ago showing that the ticks that transmit relapsing fever could be starved for 5 years and still transmit. So we know that these spirochetes have the ability to enter a dormant phase for long periods of time. And finally, we know that Borrelia burgdorferi can be found in deep connective tissues and joints. So we have to think about how well the antibiotic penetrates those tissues. So here in the United States, we have the Infectious Disease Society of America, and they have issued treatment guidelines that have fluctuated very little with compounding evidence. So they recommend in early or early disseminated phase treatment with a 10-day course of doxycycline or a 14-day course of amoxicillin. And in patients who have disseminated disease, the recommendation is the same treatment for 28 days. And this is really the model that we like to use for our animal model testing, that of disseminated infection. And if patients have clinically evident neurological or cardiac involvement, then intravenous ceftriaxone is recommended. ILADS is another medical group that focuses almost specifically on tick-borne disease, and they've issued a separate set of guidelines which indicates 4 to 6 weeks of doxycycline, amoxicillin, or cefuroxime, leaves open the possibility to retreat patients if they are not completely cured, and if they have ongoing manifestations or quality of life, antibiotic retreatment is warranted. So when it comes to studying how effective antibiotics are against Borrelia burgdorferi, there are studies of the development of persister bacteria in the presence of antibiotics that have been formed, and these studies have been performed in vitro or in test tubes. And we know that Lyme disease is most commonly treated with doxycycline, and all the determinations of what we call the minimum inhibitory concentration are performed in a test tube, not in an actual host. And we know that the bacteria grow differently inside of a host. And so that can tremendously affect how well the antibiotic works inside an actual human being. I'll elaborate on this briefly, but we've shown that Borrelia burgdorferi spirochetes can persist following standard antibiotic treatment in non-human primates. There are no apparent mechanisms of resistance. So this is a distinction between antibiotic resistance and antibiotic tolerance. Bacteria that are resistant to antibiotics will continue to grow normally in the presence of those antibiotics. However, Borrelia is tolerant to antibiotics, especially doxycycline, meaning that the drug will stop their growth, but once it's gone, they're able to regrow. So their ability to achieve this slow growing phenotype or dormant phenotype makes them tolerant to the antibiotic. And we also know that host adaptation contributes to antibiotic tolerance, and we're working on a manuscript to describe that. And we know that the persisters that we have identified are what are considered viable but non-culturable. And this is very common among bacteria. So I think you'll find that when it comes to bacteriologists and microbiologists, the tools that Borrelia burgdorferi has to survive are not unique. The infection is unique, but the bacteria do common things that bacteria do. So to me, it's not very controversial. Recently, we published a review article in MBio about the ability of Borrelia to tolerate antibiotics and become persistent. And this is a figure from the article showing that in the non-human primates, we were able to find inflammatory infiltrates, which can cause the symptoms of Lyme disease, and antimicrobial tolerant persistence Borrelia burgdorferi in a lot of different tissues. And most notably, in animals treated with doxycycline, we were still able to find Borrelia spirochetes in their brains. So this brings us to another study that we performed on an autopsy specimen. And I'm going to go through this in a little bit of detail because I think it's really important to understand the case and to understand what we found. So this was a case of a 69-year-old woman who contracted Lyme disease at age 54 with a well-documented EM rash. She had positive serology on ELISA and IgM and IgG Western blot. So she was clearly diagnosed with Lyme disease, treated with doxycycline for 10 days as per the recommendation. And this initially led to her symptom resolution. However, 2 years later, she started to develop a sleep disorder. 4 years later, her cognitive problems worsened. She had problems with processing speed, mental tracking, and word finding. She developed other symptoms, which included photophobia, paresthesias, fasciculations, and myoclonic jerks, so muscle spasms. She developed neurocognitive deficiencies, including visuospatial and verbal skills. After an MRI, it showed that there was mild atrophy and nonspecific in white matter hyperintensities. Her brain PET scans showed decreased perfusion in the right posterior parietal and temporal lobes. And just for reference, oftentimes the areas of the brain affected in Alzheimer's dementia are in the parieto-temporal region. PCR of her blood for Bartonella, Henselae, Babesia microti, and Borrelia burgdorferi were negative at this point, but we know that we can't expect to see Borrelia in the blood after a persistent infection. C6 ELISA was negative, but she did have some bands on a Western blot that were positive, 9 of 10. So she was later treated with IV ceftriaxone for 8 weeks, and this led to about 60% improvement in cognition. And then she had oral amoxicillin at a fairly high dose 3 times daily for 6 months after the IV treatment. So she was treated very aggressively in terms of how clinicians treat Lyme disease. And after this treatment, the initial improvement was not sustained, and she then was treated again with minocycline, which was of no clear benefit. Her visual spatial skills and executive functions continued to deteriorate. She developed anxiety. Her serum IgG Western blot continued to be positive. She also had Borrelia antibodies in her CSF. And a second brain MRI showed that there was periventricular and some cortical hyperintensities, possibly due to small vessel ischemia or demyelinating disorders like Lyme disease. Then she had FDG PET, which measures inflammation in the brain, and it showed diffuse cortical hypometabolism in the posterior parietal and temporal lobes, and this was consistent with Lyme disease. So finally, she was diagnosed with a REM, behavior disorder with verbalizations and movements, and a neurodegenerative dementia characterized by expressive aphasia, visual agnosia, anomia, deficits in executive function and calculation, and mild memory problems. Eventually, she developed severe oral dystonia, making feeding more difficult, and died 15 years after the initial infection with Borrelia burgdorferi. Because of the movement disorders that she displayed, her REM behavioral disorder and personality changes, these appeared to favor a clinical diagnosis of Lewy body dementia. And so we obtained her brain from Brian Fallon and Dr. Fallon and Dr. Dwork at Columbia University. And this is the method that we use to interrogate specimens from autopsies. And basically what we do is we take sections of the brain and we cut them, cut a thick piece at 80 microns, and then several thin pieces, and then another thick piece, and then several thin pieces and another thick piece. And from the thick pieces, we perform PCR to look for DNA from the pathogen. And then if we identify that, then we take the thin slices and stain them with specific antibodies to see if we can identify the intact or remnants of the pathogen in the actual tissues. And we do that for 3 rounds. And so this is the work from Dr. Dwork, where he basically showed that there was the presence of Lewy bodies and amyloid plaques. The Lewy bodies are alpha-synuclein protein aggregates, and the amyloid plaques you can see here in the darker staining regions are indicative of dementia with the Lewy body characteristics. And then we looked by PCR for DNA from Borrelia, and we were able to identify this repeatedly in the amygdala and the pons of this patient. So that's what you're seeing here. This is a positive control, and these are the 2 specimens that ended up being positive, number 1 and 3. And then from the thin slices, we stain them with the antibody specific for Borrelia burgdorferi. And this is actually from the spinal cord tissue, where you can see a very clear staining spirochete. And this went into the publication, but subsequently, we've identified more spirochetes from her brain tissue. This is in the central nervous system, visualized with a polyclonal antibody against Borrelia, Here's the spirochete, and all the blue dye, that's called DAPI. That's a nuclear stain, so it stains cells. And then here we see another one that stains positively with 2 different antibodies, indicating that it's a very specific detection of Borrelia burgdorferi. And similar studies like these have been done by Alan McDonald and Judith McCloskey, and they've also found evidence in Alzheimer's dementia patients and Lewy body dementia patients. So our studies presented here and in animal models indicate that the Lyme disease spirochete can persist after conventional antibiotic treatment. And we also believe that Borrelia may play a role in the development of dementia. We don't believe that all dementia cases are caused by Borrelia by any means, but we believe that there is certainly a microbial etiology that can contribute to the development of dementia, and that this can occur in Lyme disease cases. So if you think about Mycobacterium tuberculosis, this is a bacteria that's also very slow growing, has a dormant phase, and is difficult to treat. And the way that we treat it is with combinations of antibiotics. We don't just treat it with a single antibiotic. There are several that are used, and they all have different mechanisms. And so our rationale for treating Lyme disease should be the same based on what we know about how the bacteria grow. And so we hypothesize that by combining antimicrobial drugs which utilize different mechanisms, persisters can be eliminated. And there are a number of studies, primarily performed by Dr. Ying Zhang, who was formerly at Hopkins and now is at a university in China, showing how combinations of antibiotics, different antibiotics, can kill the spirochetes in vitro, so in a test tube. Here's one study where he tested a number of different drugs and showed that the single drugs really had no pronounced effect, but when they were combined, especially in a triple combination, that they were able to significantly reduce the number of live spirochetes. And here the drug disulfiram, which has been used to some extent for Lyme disease, was included. And here's another study which showed that daptomycin has been effective when in combination with other antibiotics such as doxycycline and cefoperazone. And another study showing in mice, in animals, that a triple combination could clear the spirochetes. And this combination consisted of daptomycin, doxycycline, and ceftriaxone. And then there's another drug that's garnered some interest in the field too, which is azlocillin. And this was studied in mice as well. And the caveat here is that the mice were euthanized shortly after the end of treatment. So we don't know how well it works against, really against persistent infection. So I'm going to talk, well, I'm not going to talk specifically about these studies, but I'm going to tell you that we have 2 studies that we've been working on, and one is a collaboration with Dr. Zhang, and it's funded by the Stephen and Alexander Cohen Foundation. And another study is a study in mice with both antibiotics and repurposed drugs. And this is funded by the Bay Area Lyme Foundation. So the goal is to eradicate the infection with Borrelia burgdorferi. And our hypothesis is that we need a combination to target all forms of Borrelia, including the persisters. And for the Stephen and Alexander Cohen Foundation funded study, we started with mice, and then we elevated the top candidates to testing in non-human primates. So there are 2 different study designs that we have, and I think it's really important. From what I've learned, it's very important to have a period of time after the treatment to allow the spirochetes to resurge and regrow if they're not killed by the antibiotic before you test them for persistent infection. And so we've done that in both of these studies. In the Zhang Cohen-funded study, we waited almost a year after antibiotic treatment because of a study that was published in mice from the Hodzik-Barthold lab. And then for the Bay Area Lyme, we wait at least 2 months before we look for persistent infection after treatment. And this is just an example of some of the data that we've acquired. This is cefuroxime on its own, and you can see that we do a number of different things to determine if the bacteria are still there, because they are hard to find and they are hard to culture. So remember, I said they're viable but non-culturable. And we've also managed to develop a new modified culture medium that improves our ability to culture from antibiotic-treated mice and non-human primates. But basically what you can see is that we fed uninfected ticks on the mice that were treated and looked inside those ticks to see if we had persistent spirochetes that were taken up by the ticks, because again, they're very hard to find, and this is how we've proven it before. We do PCR on the tick midguts, we do culture on the tick midguts, we do PCR on the tissues, we do culture of all the tissues, and so we do an extensive amount of work to determine if the mice or non-human primates are persistently infected. And you can see here that in the untreated mice, we do have quite a few positives. I think looking at the culture tissues here, most of them are positive with just cefuroxime. Most of them are positive with the untreated and with pyrazinamide on its own. But with the triple combination, none were positive here, and none were positive with this triple combination. So we know that both doxycycline and cefuroxime, when used in monotherapy, so treated on their own, do not clear the infection. And what we have found in general is that none of the single drugs that we've tested were capable of clearing the infection. However, there are certain combinations that definitely do show promise. And so for the non-human primate study, we have to do a pharmacokinetic analysis to try to get the drug levels to what they would be if you were treating a human, and what they need to be. And then we do an infection by tick inoculation to make it as close to human as possible. We let the infection disseminate for 3 months, treat them for 30 days, and then wait 5 months before we perform xenodiagnosis and look for persisters. And I'm not going to give you an extensive report on what we've learned because we're not ready to publish that yet. But I think that what we've learned is that ineffective treatment could result in very poor outcomes. And I say that because we found that treatment with doxycycline alone in some cases appears to be more, the spirochetes tend to go to the brain more frequently with doxycycline treatment than with no treatment. And we also know that it's much easier to cure mice than it is to cure primates. Classic case definition, cancer, we've cured cancer in mice 1 million times, but when you translate it into testing in humans or non-human primates, it doesn't always work the same. So it's very important that we don't run with the results that we obtain in mice. We really need to look for efficacious treatments in non-human primates. And these are just some of the techniques that we use. This is how we force feed ticks the bacteria. This is called capillary feeding. And these are the devices that contain the ticks when we place them on the non-human primates. And so it's basically something that's used for maggot therapy. And we have a little sponge there, and then we cover it with a number of different layers of tape to make sure that the ticks don't escape, because we don't want to release them into the environment if they're infected. And what's nice about this is that there's no skin irritation after we take it off. And so it's comfortable enough that I would wear it. So I feel comfortable using it for the non-human primates. Just briefly, we've also worked with a group at Duke developing novel treatments. So their goal is to look for small molecules that can actually inhibit proteins or enzymes of Borrelia burgdorferi that are needed for infection. And so they have, these are all ATP binding proteins, which is, ATP is a molecule needed for energy metabolism. And so basically you look at the proteins that bind ATP, you look for the ones that are specific for Borrelia, and then they have these huge libraries of small molecules. And when they pass it over a column that the proteins are bound to the ATP, if it disrupts that binding, then that becomes a candidate. And so we're doing this with Borrelia and Bartonella, and looking for specific molecules. Like, you know, we don't treat cancer with just chemotherapy anymore. Now we have specific targets for each type of cancer. And this is the same thing. Instead of using a broad range antibiotic, are there novel molecules that we can use that can block just Borrelia burgdorferi or just Bartonella? And this was the brainchild of Dr. Neil Spector, the late Dr. Neil Spector, who was a good friend and colleague and a brilliant man. So with that, I'd like to thank my funding from the Stephen and Alexandra Cohen Foundation, Focus on Lyme, the Bill and Marion Cook Foundation, Bay Area Lyme, and Global Lyme Alliance, my collaborator, Dr. Ying Zhang, the members of my lab. These are the technical staff, and then students and former lab members and different folks in different divisions at the Primate Research Center who have helped us, especially the veterinarians. They take really good care of our animals and help us make sure that we do research well. So with that, I will conclude and take any questions.
Thank you very much, Monica. That was massively interesting. We've got a couple of questions so far, so should we just go on with those? In fact, they're now coming in one by one. So the first one I'd like to ask you is, why is it that despite all the scientific evidence, doctors here in the UK still resolutely refuse to even consider the possibility of persistent infection in patients with continuing illness? Is there anything we can do to change this?
Yeah, that's a common question and a very good question. And I think it's a challenge because we don't have good evidence of persistent infection in humans. And the reason that we don't have it is because it's very difficult to obtain evidence of persistent infection in humans. There was a xenodiagnosis trial, and I think they had a really hard time getting larval ticks to feed on people and analyze those larval ticks. But there were a few that were positive, and I think the only way we can really prove it or demonstrate it, because it's so hard to see, it's so hard to find. It's not like a urinary tract infection where you can just culture the bacteria. We can't find it in the blood. We can't find it in the CSF. We can't find it in the tissues or specimens you would normally collect. We have to look in, like in the animal models, we have to literally look in the tissues or feed ticks on them to find the persistent spirochete. So I think the work that has been done and will continue to be done with specimens from autopsies, unfortunately, and hopefully in the future from surgical discards like knee replacement surgeries, will help to get the clinicians and physicians to understand that this, yes, this can be a persistent infection even after antibiotic treatment. It's not a question to me after all that after all that I've done. But yeah, and they have to read the papers too.
Yeah, one of the questions in the chat box is, when do you expect to publish your results?
That's a good question. We'll publish the mouse studies first.
Yeah.
And the non-human primates should be soon after. I would give it 6 months to a year probably, but within a year.
Okay. There's some very long questions. So this one, neurological infection is common in syphilis, another spirochete infection. Clinical evidence suggests this is common in persistent Lyme disease also. In particular, this is common in persistent Lyme disease also. In particular, antibiotics that cross uninflamed blood-brain barrier, such as cefuroxime, minocycline, rifampicin, are useful. However, antibiotics that don't, I think that doesn't cross the blood-brain barrier with, such as vancomycin, God, it's really long, this, daptomycin, and another one I can't pronounce, azacillin, show little activity in patients. Why do you think this issue is not discussed more?
Oh, yes, that's a really
long one. Yeah.
Yeah, a long question, but a good one. It's very important, I think, that that we do utilize antibiotics that cross the blood-brain barrier, because after a period of time, if you have a disseminated infection, they're going to get to the brain. And I don't think doxycycline's not doing it. And that's one of the reasons why we are working on this multi-pronged approach to ensure that we can eliminate the spirochetes wherever they may be, and arm clinicians with the right tools to be able to eradicate the infection.
Mm-hmm. Okay, so this is a bit of a shorter one. May I ask a question, please? With what tinidazole can be replaced in the treatment of Lyme? What does that person mean? What can you use instead of tinidazole?
Oh,
I don't know.
My perception is that is an antifungal, but I'm not quite sure.
I think it is.
Yeah.
Yeah. I'm not really sure exactly.
I think there are a lot of antibiotics out there that are going to do a lot better job than doxycycline. I'll say that.
Okay. Right. This is quite a good one. Something I'm interested as well, about sleep being disrupted with a Lyme disease infection, because that happened to me really badly. No sleep at all for days and days on end, and just nobody could find a way of getting me to sleep. It was very distressing at the time. So somebody's put, I presume that they mean rheumatoid arthritis, and sleep apnea seem to coincide with Lyme diagnosis. Do you have any idea why?
Not specifically, but I will say that it's not. We've seen invasion of many parts of the brain, and inflammation in many parts of the brain from a Borrelia infection. So, it's certainly possible that the brainstem is affected, including the pituitary gland. And so I think the manifestations that you see from Lyme disease are probably a result of where they are inducing the inflammatory responses in the brain, and peripheral nerves. We frequently see perivascular invasion, proliferative lesions around the perivasculature of the peripheral nerves, which explains why people probably have pins and needles and all sorts of peripheral nerve involvement.
Yeah, I think you are correct. I think some people get inflammation in different parts of the brain, and different activities are affected, because certainly, again, that happened to me. I had different activities being interrupted in a sort of rotating, it just was crazy. You know, one day couldn't do this, one day couldn't even write, that sort of thing. And I think you're right. It depends what's infected in the brain.
I should have said hypothalamus, sorry. Yeah,
Yeah,
thalamus,
hypothalamus.
yeah.
Because a very senior neurologist who knew nothing about Lyme disease long before I realised I had it told me he didn't know what had happened, but he said something has happened to your hypothalamus, but science isn't that far on that I can tell you what. But he said, I bet you've had an infection or something. So actually, knowing anything about, you know, what had happened to me, he was absolutely bang on, I think. Right, so well, there's one about, which I'm not sure is your field at all. It says, do you have any opinions about the use of amitriptyline against Lyme and co-infection? So amitriptyline is an anticonvulsant used for nerve pain, so I don't think it would act against Lyme and
No, that's a better question for a clinician, I think.
Yeah, absolutely. It would help nerve pain, as far as I know. Thoughts on the potential new antibiotics like aslacillin, hygromycin A? Are they now our holy grail? How long do you think we might expect them if they're proved to work? Oh,
I'll just reiterate what I said and what I found is that no single drug has been effective at curing the infection. And I think that probably holds true for those as well. But I think they definitely have the potential to be combined into a very effective regimen. And it's just something that we really need to test empirically, hopefully go from non-human primates to human clinical trials and look for objective signs of improvement.
this is a good one for you. I'm sure you'll like to hear this. How can we help fund your work? Your work is greatly appreciated.
You know, I guess the Cohen Foundation doesn't take donations, but Global Lyme Alliance takes donations, and so does Bay Area Lyme. And those two organizations have been very supportive of our research, and they especially in the area of treatment, because the federal government in the US does not fund treatments, because the prevailing theory is that the antibiotics we're using are effective. And so these foundations have really stepped in to help fund treatment studies.
Oh gosh, we've got quite a lot of right. I'm not sure about this one, because I'm not really sure what the person's referring to. Given that the amyloid cause of Alzheimer's disease was based on fraudulent data, what can we do to have Lyme borreliosis as cause properly evaluated in support of Dr. McDonald's work?
Yeah, that's a complicated issue, because I think beta amyloid is still involved in the etiology. It's not directly responsible. And I think that's why none of the amyloid busting drugs have actually worked. And it's always disappointing to see, it's bad for science when people, you know, fabricate findings and in general. So, you know, I think continuing to look the way we're looking with the pathology and the, you know, clear, distinct, specific reagents that will find Borrelia or other pathogens in the brain is really how we have to go about this.
Mm-hmm. Definitely. I'm not sure about this one. If I'm reading it correctly, it might be an organization in the States. So it just says, a question for Dr. Embers. Thank you for your contribution. I was bitten by a tick in 2005 and I can't read, and something Raspberry Scientific Incorporated are a small startup. So I presume that's just information for you if you know that organization.
I don't, but thank you.
Are you seeing a recognizable immune signature in persistent Lyme, T cells or B cells? Thank you for your great work, Monica.
That's a good question as well. We haven't done that work specifically. We've done a little bit of work with the subsets that are activated during B and T cell subsets that are activated and affected during infection. But I think, you know, the lab, Dr. Charles Chu's lab is looking at signatures, and other people are looking at signatures. And there's definitely a well-characterized immune signature for acute, but then when you look at persistence, it varies quite a bit. So I think it's still going to be a challenge to find any type of specific biomarker, but that's definitely something that we hope to explore in the future in the non-human primate model.
Yeah, we look to the future with hope. Okay, I don't really think this is your field. I'm currently being treated for Lyme disease and gone through several combinations of antibiotics alongside herbal supplements. Do you think that herbal supplements and other natural approaches contribute to a significant effect on treatment or not?
That's a really interesting question. And I think from the pragmatic scientist side, we need to test these in not only in the test tube, but also in humans or in animal models. And I know that, there have been things like carvacrol, which comes from oregano, which is known to have some antibacterial properties. So I think it's worth looking at some of those herbal remedies from a traditional efficacy, study in animal models to see if they have the ability to actually target the spirochete specifically. What you don't want is something that has a more global effect that could disrupt the microbiome or other cells in your body.
Somebody's telling the other person who asked a question how they can fund your work. Through Amazon, you can set your account to different charities. So if you have a look on Amazon Smile, you can find Bay Area Lyme Foundation on it. Please don't make me say this whole word. I'll try. How do you feel about SOT, which is supportive
oligopeptide therapy?
Yeah, that one.
I haven't actually seen a whole lot of data on that. I think there's we have some interest in immune therapies, and I think again, it's something that hasn't been studied enough to really make a qualified decision about or opinion on.
So that's just a couple of questions down. Do you have any opinions on low-dose immunotherapy for post-treatment Lyme disease?
Yeah, it depends on the type of immunotherapy. There are certain, a lot of the biologicals now target different cytokines or chemokines that are produced by immune cells, and I'm really interested in ways that we can target the bacteria specifically, because we know that doxycycline doesn't work because it relies on an immune response. But what if we can treat with doxycycline and then boost the immune response in order to clear the infections, or treat with another antibiotic and boost the immune response specifically against the spirochetes? And that's something that I have a doctoral student working on now.
Oh, right. That's really interesting. Somebody's asking, obviously this is not your field, but they can't understand why painkillers don't work with some aspects of Lyme disease. Do you have any opinions on that? Are they just not targeting the areas that kill pain in certain areas? A lot of people complain about painkillers don't help them with Lyme disease.
Yeah, I mean, with the perivascular inflammation around peripheral nerves, maybe it's just not the right treatment. Maybe reducing inflammation in combination with painkillers would be more effective.
Yeah, it's the inflammation that's driving the pain. Okay, there's loads here. We're not going to get through them all because we've only got 7 minutes, but I'll try my best to go through them. How would you respond to somebody? I know you're not practicing MD, but some people can't tolerate any antibiotics or herbs. Is it just that individual for some reason can't tolerate because of the bacteria, the way it works? Or I know it's difficult for people who can't seem to tolerate any sort of treatment.
Yeah, I mean, every antibiotic is sort of a different class and has a different function. And so hopefully there's something out there that could be effective. Like, I don't want to advocate for disulfiram or loratadine, but these off-label drugs, we're starting to look at those for their ability to help patients who have Lyme disease, for their ability to kill the pathogen. And I think the novel drugs that we're trying to develop with Duke would be very useful as well. We can get there.
Okay. Do you see any promise with Dr. Horowitz's new high-dose dapsone combination? Have you worked with dapsone? No?
We have actually. We've looked at dapsone, and in mice, it is very effective, and not on its own necessarily, but definitely in combination. And almost any combination that we put with dapsone is effective. But I should caution that there are some side effects from dapsone. So if a physician is using it, I know Dr. Horowitz knows, what the side effects are, and he monitors his patients very carefully. But I think dapsone does have some potential.
There's a question here that I can probably answer. So it says, are there any trials of combination therapy for Lyme starting in the UK? Not that I'm aware of. Not actual trials. And
I don't think there are any in the US either.
No, I don't think there are. Yeah. So this is similar to the other one. If you react significantly to antibiotics and become more unwell, does that mean the antibiotics is hitting the bacteria? There's always lots of questions about that, whether it's a good thing or a bad thing. So
yeah, that's commonly called the Jerisch-Herxheimer reaction.
Yeah.
And it can be a good thing, but it doesn't necessarily mean that it's eradicating the infection. So you have to be careful. So
the message I read out earlier that I wasn't quite sure of, the person has put I sent my message too fast. So it said, thanks for your contribution. I was bitten by a tick in 2005 and further found Raspberry Scientific Incorporations, a small startup company in Quebec. They are working on developing an ELISA profiling tool to systematically screen patients for co-infections using 250,000 immunoprobes. Do you previously achieve the time course antibodies titration? This is way above my head, of treated versus untreated Borrelia burgdorferi infection. I'm not, that's
I can take a little bit of a stab at that. I just we did a study in non-human primates where we looked at how the antibody responses changed over time throughout the course of infection. And if you're looking at one antigen, it might go up and then come down. If you're looking at another one, it might go up and stay up. If you look at another one, it might decrease with antibiotic treatment. So there's clearly variation in the antibody response over time throughout the course of infection that's not encompassed in the necessarily in the test that we're using. And there's also the ability, and we've also had non-human primates that are seronegative from all the tests that we've done, and we know that they're persistently infected. So there's an interest in looking using things like peptide arrays and machine learning, and this may be what the participant is talking about, to identify other antigens that could be targeted that we're not picking up with our normal diagnostic tests. And so we're very interested in improving diagnostics as well. We're in all of it.
Yeah. So we're not far off our hour. So there are quite a lot of thank yous to you for your groundbreaking work and publications. Loads and loads of thank yous, which I'll copy and paste to you after the event. Let's see if I can find one more question to start, finish. Sorry, loads of thank yous now. That's really nice. So this one, anti-malarial such as artemisinin, I can never say that one either, and methylene blue have been shown to have striking activity against Borrelia persistens. However, research into these chemicals is still sparse. Are you investigating them at all?
Yeah, well, I can speak to artemisinin, and we have tested that in mice, and on its own, it's not very effective, and even in combination, it doesn't appear to be very effective. But in methylene blue, I'm most familiar with it in Bartonella treatment, and that's something that we may hope to test in the future in animal models. It's been shown to be effective against Bartonella in culture, but not in animals. So
okay, that's brilliant. Right, so we're just coming up to 8 o'clock, and we've had loads of messages on the chat. Massive thank you to you through the chat box. I will copy and paste them and send them all to you so you can see them. The whole team at Lyme Disease UK want to say massive thank you. We really do appreciate people like yourselves giving up time to speak to the online communities and the guys in the UK. It's been an absolute pleasure to meet you. When I sign off the session, it signs off for everybody, but I will come back to you via email, so don't think I've just cut you off. Okay.
And I want to say thank you to everyone who joined too, by the way, and to you for the invitation.
Oh, you're absolutely welcome. Absolutely made up when you agreed to speak to us. So thanks again. I'll send you the chat box so you can see all the thank yous, and say massive thank you to everybody who registered tonight. We really are sort of enjoying giving these presentations to the UK community. So there'll be another run along soon, I'm sure of it, when I can persuade somebody else to chat to us. Thanks ever so much, Monica, and I'll be in touch via email. And thank you to everybody. Thank you. Good night, everybody.
Bye-bye. Good night.